Correct. KEYNOTE-522 was a preoperative as well as adjuvant trial in triple-negative breast cancer patients comparing standard backbone of chemotherapy with a randomization to pembrolizumab, which is a PD-L1 antibody, versus placebo. And patients received 24 weeks of standard chemotherapy that was taxane, platinum, anthracycline based, and then they had a randomization between pembrolizumab, a PD-L1 antibody, PD-1 antibody, versus placebo, concurrent during the chemotherapy phase for every 3 weeks. Then the patients went to surgery, and one of the primary endpoints was pathological complete response at the time of surgery. And then in the adjuvant setting, they were randomized, or they continued study drug, either pembrolizumab or the placebo, for 9 additional treatments every 3 weeks. So at ESMO in September, one of the primary endpoints, pathological complete response, was released, and that improved from 51% to 64%. That is a dramatic improvement compared to standard chemotherapy alone. Historically, that's been in the range of 40 to 50%. And we believe that pathological complete response is a surrogate endpoint for improved longer-term outcomes. So that's a big inroad into this type of disease, triple negative, which has a lack of targeted therapies indicated for it. Interestingly, also at ESMO, they presented early data regarding event-free survival, and it's early. At 18 months, we're seeing an improvement in EFS from 85% to 91%. That needs to be followed longer term, but already there's a signal there could be an event-free survival benefit as well. So when they looked at the toxicity during the concurrent chemotherapy arm, the majority of the side effects were related to the chemotherapy backbone. There were some signals, though, that this therapy, the antibody, the immune therapy, can have autoimmune phenomenon like hepatitis, pneumonitis, colitis. The incidence of those episodes is under 2%, whereas thyroid dysfunction can be as high as 14%. So those are some unique side effects related to the pembrolizumab. The PCR is an inroad into improved outcomes. The fact that we can improve the PCR rate from 40 to 50% up to 64%, and because that translates to improved outcomes, we believe that to be a surrogate marker of benefit. And to date, the standard of care for triple-negative breast cancer is chemotherapy only. We don't have other targeted therapies, so this is the first study to show a targeted therapy, in this case an immunotherapy, pembrolizumab, offering that benefit. So sure, at San Antonio 2019, they are going to release some additional subset analyses looking at differential benefits in different groups based upon stage, the PD-L1 positivity, and lymph node status. So that may give us some further insight into, are there certain subsets that benefit more so versus not. The FDA already gave it a early therapeutic designation status, but until there's a further review of data and a further approval, it's not currently standard of care.